So ADH, antidiuretic hormone. So we're moving on to like proper endocrine. We spent time with diabetes just previously, right? And diabetes dealt with maybe a little bit of growth hormone caused the rise in blood sugar, right? Right, the lipolysis, increased blood glucose, and diabetes is a good, 80, 90% of our endocrine disorders. But now we're going to talk about the other 10%, right? So the 10%, we're not going to worry about GU stuff. We're not worried about estrogen, testosterone. That's a whole subject in of itself. Might take about like maybe prostate cancers. Might deal with some male testosterone stuff that we might maybe deal with, but all the estrogen stuff would be more of an obese situation, right? Growth hormone, that's pediatrics. Don't really care about that, right? And then we have, again, prolactin, lactation specialists. They can deal with that, right? And then we got thyroid. So thyroid, we're going to spend some time on, right? So we'll talk about T3, T4, TSH, and all that fun stuff. And then we'll spend some time with some, with what is it called? With our steroids, right? ACTH releases our glucocorticoids. We talked about glucocorticoids a little bit, right? They raise sugar, they proteolyse, they lipolyse, they glycogenolyse. They are going to raise the sugar, right? Also, just a note here before I forget, cortisol actually inhibits thyroid release. So this top portion over here is how release of hormones is regulated. Usually things are a negative feedback mechanism, and we'll talk more about negative feedback when we talk about thyroid, because that's a good explanation. ADH is not on negative feedback. We talked a lot about ADH and how it works in diabetes, right? But it's not on yeah, I guess it was on negative feedback, but it's not based on chemicals. It's not like ADH gets released and another hormone gets released to then inhibit ADH. That's not how it works. ADH gets released when angiotensin 2 is around. It gets released when the SNS fires off, right? The SNS fires off, that releases vasopressin, right? Also, SNS releases the release of down here some steroids too, right? When our plasma volume is low, which is the same thing as saying when we are dehydrated, when our osmolarity is high, those are situations where ADH would then get released, right? So ADH is what we're talking about right now. ADH gets released when we have stress, right? Which with SNS, angiotensin 2 gets released, and that's also what else when that happens. When else would ADH get released is when we have low plasma volume, low blood pressure. Low blood pressure is going to vasoconstrict, right? That's the job of our vasopressin or ADH, right? The other job of ADH we talked about diabetes at length was to antidiurese, was to get released when the plasma osmolarity or we are super dehydrated, which could cause low plasma volume, low blood pressure, but it's gonna, when a plasma volume is very, very concentrated, we're gonna add water to that to make it less concentrated or to reduce the plasma osmolarity, right? By increasing reabsorption of water, by promoting your reabsorption, and causing a dilution of our bloodstream. And hopefully that will correct our dehydration situation, right? And if you do that too much, you can get low sodium. That's going to dilute out our sodium levels way too much, right? So we'll talk about too much ADH or inappropriate amount, and we'll talk about too little ADH, right? Or diabetes insipidus. So too much is a syndrome of inappropriate, right? So SIADH. And then DI has two flavors. There's a nephrogenic and a neurogenic. That didn't really work out well, right? So you have a nephrogenic and a neurogenic variety of DI, which we'll talk about in more detail. So the action of ADH is a recap. We talked about dehydration, hyperglycemia, causing the hypothalamus to release vasopressin, and that will then cause increased blood volume by diluting out the serum, hopefully fixing the dehydration, right? Also, low blood pressure can happen with dehydration, but just low blood pressure, SNS will also trigger vasopressin to be released. It will bind to vasopressin 1 receptors, causing vasoconstriction, increasing SVR, increasing our blood pressure. Increased blood pressure will then inhibit the release of ADH. It's all on a little negative feedback mechanism, right? So that's what ADH general function is. And it's stimulated again by increased serum concentration, osmolality, specific gravity, however you want to say it, right? Dehydration, right? Those are all the same thing, osmolality. Okay, so those are all the same thing. Just super concentrated means super amount of ADH to hopefully go all the way down to the kidneys. It gets released from the little ball sack of the brain, right? That's the pituitary gland, right? It goes in there. It's going to vasoconstrict, hopefully raise our blood pressure, and then it's going to go all the way down to the collecting duct, and it's going to absorb urea. And so here's another picture down here. Water gets absorbed with ADH, and then urea also gets absorbed, and water follows, right? So urea also. And water will follow that at urea, therefore restoring my concentration back down to normal, which is what again? What's a normal serum concentration? Normal is 280 to 300. That is perfect. Specific gravity is different, osmolality is a little bit different, but 280 to 300 is a normal osmolarity, right? What else triggers vasopressin is SNS and angiotensin 2, right? Those guys usually are firing off when the blood pressure is low. It's really bad when someone has CHF and they're in cardiogenic shock, but yeah, the ADH is part of the problem in that situation. So what will happen when this fires off? You will lower the serum osmolarity. That's what it will do. It will retain water at the V2 for tubules, right? It will then work there and will, along with aldosterone, which also gets stimulated with the RAS system when the blood pressure's low and we have low circulating volume, that will then hopefully restore blood volume. And then when our blood pressure is low, that will also be fixed by the action of vasoconstriction by vasopressin, right? Remember vasopressin, ADH, DDAVP, arginine vasopressin. It has 6 different names, but it's going to do basically 2 functions at these 2 different receptor sites, right? So here's ADH in the mix here, right? ADH is going to be released by the brain, by the posterior pituitary. It's going to go down the kidney, and it's going to increase blood volume, hopefully restoring cardiac output. And of course, if you are super dehydrated, that will also trigger ADH to be released. All right, so normal serum osm, 280 to 300, osmolality, concentration, specific gravity, those are all approximately, they're all the same thing. Usually 280 to 300 is going to be your osmolarity, osmolality. Okay, so that's how it works. What happens when it doesn't work? What happens when ADH is not present? What happens when ADH is present, but it can't work on those tubules? Those tubules do not respond, right? They are striking. They're saying, nope, not today. We're not going to do this because we've been raised by pyelonephritis, right? Or someone's taken lithium, and lithium has inhibited the ADH action at those collecting ducts, right? So we can call this neurogenic or nephrogenic DI. So neurogenic means no ADH is being released. There's no ADH being released. I'm going to have no ADH. ADH is called antidiuresis. So if I have no antidiuresis, what am I going to have? Diuresis. You're going to have polyuria. So if you're saying, if someone's asking you, wait, you're emptying that Foley bag again? These Foley bags hold about 2 liters of urine. So if you're emptying more than 2 liters in a shift, that's a problem, because greater than 50 mLs per kilo per day is a lot, is definition of polyuria. So more than 3 liters per day, that's like 24 hours, right? If I'm doing 2 liters twice my shift, that's already 4 liters. That's already polyuria. And polyuria is only caused by a few things. One is DI, right? A lack of ADH, right? Central or nephrogenic DI. Also, it could be hypercalcemia can do it, so high calcium can pull a lot of water with it. But then we have our formula that we're used to, right? We got 2 times the sodium, so if the sodium is can pull a lot of water, especially like diuretics would be the reason for that, right? We got a BUN that's super high. We have a glucose that's super high that we talked about in diabetes, or we have an ETOH that's high. That can also cause us to be polyuric, right? All these things will pull all this water into the urine. And albumin can happen too. If my glomerulus is destroyed, right? My glomerulus usually does not allow protein through. But if I have like glomerulonephritis, so I have a nephrotic syndrome, and albumin is leaking into my glomerulus, there's no transport that can put that albumin back into my bloodstream. So that's going to pull water with it, because albumin is actually 70 times stronger than sodium, right, at pulling water. So we have solutes that might pull the water and make us polyuric. But when someone's polyuric, the first thing we're probably thinking of is is there something neurogenic going on, maybe nephrogenic, right? So are our kidneys not responding to ADH, or do we have a central reason? Is there a brain injury that's causing us to not release ADH anymore, a brain herniation, for instance, right? There's too little ADH being made by the pituitary. Maybe there's a bleed in the pituitary, right? Or a compression of the pituitary. Increased ICP is causing my damage to my pituitary, my hypothalamus, making it so I don't release ADH, right? That would cause me to have polyuria or central DI. And there's such thing as nephrogenic DI, where right back there in the working parts of the distal tubules, I have a little ADH receptors. Those ADH receptors are fried because of pyelonephritis. They're fried because of a severe infection or, let's say, stones or something like that. That could be a reason why I have no response to ADH. Other reasons could be like I have lithium, for instance, is a common example. Certain diuretics can also inhibit it as well. Like they're like taking tolvaptan, which is an ADH antagonist. Well, that makes sense. That's why they have this situation happening, right? So that's the two types of DI. Next, we'll talk about the reasons for it. So reasons would be they have a central-wise, their hypothalamic compression, right, or pituitary damage. They got a severe autoimmune reaction. They got ETOH activity on the brain, right? They have nephrogenic reason. Most common being lithium. Lithium is not prescribed that much anymore, right? What else? They have cisplatin as a chemotherapy drug. We have something infiltrating. They have something that's damaging the nephron itself, right? Specifically that distal portion of the nephron. Okay, so how do you know someone has DI? Well, they are peeing a lot or little. They're peeing a lot. They're peeing a lot of free water. A lot of, not just sodium in water, but free water, because that's what ADH does. It absorbs just free water. So I'm losing all this free water, and therefore I'm just losing water. I'm not losing sodium. I'm just losing water. So if I'm just losing water, that's going to make my serum sodium what? Yeah, because it gets a component of sodium plus water, right? That's what makes up my serum, right? If I'm losing just water, that I'm going to have high sodium, right? And high sodium is synonymous with high concentration, because I've taken the water out of my Kool-Aid. My Kool-Aid is more concentrated, right? So I'm going to have a very, very high serum osm, a very, very high serum osmolarity. What about my urine? Well, all that free water is being dumped into my urine. So all that water is being added to my urine. Therefore, my urine osm is going to be very, very low, extremely low, okay? So that's the two things that would kind of clue you in that they have a DI happening, right? They have a really, really high serum osm, and the urine osm is very, very, very low. Okay, there's a test. I asked our lab if we can do it. We can't do it just yet. It's called copeptin. It's a precursor of ADH. When ADH gets made, there's also copeptin, which is part of the manufacturing process. It got cleaved off, got cut off, right? Just like if you're making like a 3D print, anybody who does 3D printing, they have these little struts that you have to clean off first, and then you get your 3D print model, right? So that's what copeptin is. Those little structures that are going to be present if you're making ADH. So if you have central DI, you're going to have negative copeptin because you weren't making ADH in the first place. If you have nephrogenic DI, you're making ADH. You have copeptin. It's just not responding to it. Okay, so that's what copeptin would be present in would be decrease in nephrogenic DI. And then we have desmopressin challenge is something we can do to see if they have if they respond to ADH. If I give ADH to a patient, or DDAVP, which is his other nickname, right? If we give DDAVP or ADH or AVP or whatever you want to call it, vasopressin, to this patient who has central DI, will it affect their kidneys? Will it work on the kidneys? Yeah, the kidneys work. It's central DI. The brain is not working, right? So my kidneys down here, I've got brain up there. If I give DDAVP to this patient, right, I give ADH to this patient, the kidneys respond, right? And my urine output goes down or up. If I give ADH and the kidneys respond to it, I should have a decreased urine output because ADH is working. If I have nephrogenic DI, then I give ADH, it doesn't work. I'm still going to have polyuria. I might have a little bit of response, right? There might be still some nephrons that are going to like stay the line, and they're still going to work a little bit, right? So we can see the desmopressin challenge. If I give them ADH, right, All right, I say this, it's still very, very dilute. I still have a serum osm that's still high, right? That is someone that has nephrogenic DIs. That's what a desmopressin challenge is. I give them ADH, see what happens. If I give them ADH, the urine output goes from 2 liters in 4 hours to 100 cc's in 2 hours, right? And you usually just check it 30 minutes later. You don't like wait 2 hours, but you check it after 30 minutes and the urine output goes all the way down. That means it was central DI. So I had a response by the kidneys. That's central DI with a desmopressin challenge, right? But if I give desmopressin and there's still a urine osm that is that's extremely low, right? That means I have very, very dilute urine still after I give ADH. That means my kidneys aren't responding to ADH, because if they responded to ADH, I would have had a very, very concentrated urine. So that's what the desmopressin challenge does. The water deprivation challenge, similar. It's only done if you have someone walking into the unit drinking those big Stanleys that are like 4 gallons, right? And it's someone that overdosed on water, right? That's psychogenic polydipsia, borderline. If you saw someone come bringing those huge, huge gallons, right? And if you stop the water intake, your body should naturally stop peeing, right? It was just the overflow of water that was causing the problem. Okay, so what else? So how do you fix this? How do you fix someone with central or nephrogenic DI? If they have central DI, just give them ADH. That's the fix, right? They're not making ADH anymore in their brain, so therefore I need to give them ADH parenterally, or I have to give it to them outside the brain. And the common way to give that is intranasal. All right, so intranasal desmopressin, or DDAVP, is what they'll be discharged with, right? Or they might be, it might just be a brief situation, right? But usually there's a good reason why they're not producing ADH anymore. And then if they have nephrogenic DI, we can like kind of trick the kidney with actual diuretics. Like, why would I give diuretic if someone's peeing, right? Too much. So these diuretics are going to fool the kidney a little bit. They play with the ion channels. Okay, and for lithium, like this lithium induced, we can block that with amiloride, which is a diuretic, right? So that's what would happen with nephrogenic DI. And of course, treating the underlying problem is a good idea. If someone has a brain herniation, I should fix the brain herniation. If someone has a raging pyelonephritis, I should fix the pyelonephritis, because those two things are causing either nephrogenic or neurogenic DI. So switching gears, we're not dry inside anymore. We're not DI, right? We're not dehydrated. We are soaked inside. We have too much ADH. Someone would even say inappropriate, right? They have an inappropriate amount of ADH. So it's a syndrome of too much ADH. And why is that? It's because they have their ADH is secreting way too much. And so the answer for any endocrine disorder besides diabetes is that there's a tumor, right? So they have a tumor. That's why there's too much of a hormone or too little of a hormone. So going back to DI, it could be a neurogenic DI that is because if there's a tumor on my hypothalamus that's making it so I'm secreting too much or too little ADH and DI. And DI.
And DI is too little.
Too little. So it could be a tumor on my hypothalamus, and that's why I'm not making DI. And SIDH, it could be a tumor on my hypothalamus, making it stimulate the release of ADH, right? There could be a tumor on my kidneys, making so my kidneys don't respond to ADH. That's nephrogenic DI. So tumor is usually always the answer for anything endocrine. That's why I mentioned that there's, these disease processes for endocrine are extremely rare, and they are because of a tumor usually. That's usually the answer. Okay, so I have excessive ADH secretion because of a tumor of some sort, right? So they have a malfunction of the posterior pituitary, right? It could also be due to compression. So increased ICP causes DI, and increased ICP could cause SI. So it just depends on how the brain's reacting at one point or the other. So we'll see that. We'll see that all of a sudden they are peeing a whole bunch, and all of a sudden they are not peeing at all. So does one come before the other? It's really not hard. It's hard to predict, right? We just know that there's something going on in the hypothalamus. Okay, either it's increasing ICP, or there's a tumor, right? Another common thing you'll see with SI is they got a pulmonary tumor. They got a tumor, an oat cell tumor, or adenocarcinoma of the lung. Also, just pulmonary disease of some sort. So because like a severe pneumonia can actually make the cells of, can actually stimulate the ADH release as well. So that's the common thing that causes SI, or too much ADH. And if I have too much ADH be released, what's that going to do to my urine output?
It's going to kill it.
It's going to have too much ADH is too much antidiuresis. Too much antidiuresis is no diuresis. So I have olyuria, or I have decreased urine output. I don't have polyuria more than 3 liters per day. I have olyuria, right? Less than 400 or 200, depending on the source, per day, right? But usually we know our AKI definitions, less than 0.5 per 12 hours or 0.3 per 24 hours per hour per kilo. So what else will we look at? So we can look at the concentration of the urine and the concentration of the serum. So what's the concentration of the urine going to be if I'm not peeing water?
If you're not peeing water, the concentration will go down.
Concentration of my urine will be extremely concentrated because all the free water that would go in the urine is being reabsorbed by ADH, because ADH is present, and what ADH does on those V2 receptors of the distal ducts of the nephron, they're going to take water and put it back into the serum, right? And dilute out my serum, so therefore I get a serum sodium that is low, right? It's a euvolemic. These patients usually are not fluid overload. They're not really truly fluid overload. They're just diluted, right? You have too much ADH. Your kidneys are working just fine, right? So they have a serum sodium that is very, very low. They have a urine concentration that is extremely high, right? Because they are not putting water into the urine. And the serum concentration is what? High or low?
Serum concentration will be low.
So they have a very, very low serum osm, right? So it'd be a less than what? The normal serum osm?
Less than 280.
Yeah, less than 280, right? It would be a dilute serum. And that water absorption, all that water absorption and that volume status, that is good, right? That is not so much the point of fluid overload, but that's going to start inhibiting aldosterone, right? Inhibit aldosterone, you're going to get a rise in urine sodium, right? Because aldosterone was inhibited. I have great GFR. My GFR is beautiful. It's just, it goes all the way through there, and then it just gets reabsorbed right back into the circulation because I have an inappropriate amount of ADH. So what's my goal for treatment? My goal is to pull off the excess water, okay? So we're going to get that serum sodium rising. So they might give like 3% saline, right, to get that sodium to rise. And usually we give, ironically, we give ADH. We want if we were to overcorrect it. So I should put a caveat there. So we want about 6 to 8 MEQs rise. But what happens if we go like 10 MEQs in 24 hours? What's going to happen? If you overdo it, you overcorrect, you go more than 6 to 8 MEQs per 24 hours, you can get central pontine myelinolysis or osmotic demyelination syndrome, which is a permanent neurological deficit, right? So you have to, sometimes you might even add ADH to get that sodium back down to 6 to 8 per 24 hours, right? Because sodium is the only electrolyte where you can say, oops, 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 and you can back it up. And as long as you correct it within 24 hours, you're good. So you might even see ADH given to an SIADH patient. Like, what the heck? They have too much ADH. The only reason why they're giving ADH to your patient is because they overdid it, right? So you give 3% saline to have a nice rise in your sodium, about 60 MEQs per 24 hours. That means we better be checking sodium every 4 hours, right? You don't want to check it after the 36-hour mark. Oh, we overdid it yesterday, didn't we? Oh yeah, I guess we'll just hope nothing happens. Because in 2 days, 48 hours, they're going to have this permanent neurological deficit of CPM, or osmotic demyelination, or central pontine myelinolysis. Okay, we don't give normal saline to these patients because, like with the aldosterone situation, I give fluid to this patient. My patient's going to say, whoa, that's way too much fluid in my nephron. I'm going to not release aldosterone now because aldosterone is released with decreased GFR. So if I don't release aldosterone, I am going to get rid of sodium because aldosterone is what absorbs sodium, right? So I'm going to have a desalination plant out on my hands. If I give normal saline to someone with SIADH, it's actually contraindicated. It can cause a life-threatening drop in someone's sodium. And what happens when someone's sodium drops too fast? What symptoms will you get? So sodium has CNS symptoms. Sodium CNS is going to be it could be a seizure activity, it could be definitely get altered. All right, and in those cases, if we drop it too fast, we might have to give a bolus of 3% saline or like 2 units of bicarb, right? 2 units of bicarb is going to definitely be given if they have a seizure activity, right? Furosemide will get rid of water more than sodium, so that's why you're given diuretics, right? Urea we talked about with hyponatremia is osmotically active. It's going to pull water with it. All right, so that's gonna, if their kidneys are working, right, we're gonna give urea. It's gonna pull free water with it, right? So you might see Vaptans be given. Vaptans are ADH antagonists, and they are not predictable. So they are not great to give. They can overdo it. Okay, so does that make sense? So DI versus SI, there's several differences. One has high urinosum, one has low urinosum. Which one has low urinosum?
Low urine osm would be DI.
So DI has ADH that is not responding, right? The ADH is not being made, or the kidneys are not responding to it. Therefore, my urine is going to be very, very dilute. My urinosum is going to be very, very low. My urine-specific gravity is going to be very, very low, right? Compared to like serum sodium. What's the serum sodium going to be in SI?
Serum sodium will be also very low.
Serum sodium in SI will be low because the water is being taken from the distal tubules and put back into the bloodstream, diluting out my sodium, compared to DI where I have an increased serum sodium, right? And in DI, what's the serum osm going to be?
Serum will be super concentrated.
Super concentrated as well, because there's no ADH to take water from the urine and put it back in the serum to dilute out my serum. So I lost that, therefore I get concentrated. All right, so those are really the key tests: serum osm, urine osm, and the serum sodium. Those three things we're going to be looking at to see, and of course the urine output can help too, but we're looking at those three things, and that's going to tell us if it's a DI problem or an SI problem.